Okay, it is right at 12 o'clock, so we'll go ahead and get started with this presentation. Before we get started, if you would not mind clicking on the chat conversation icon box at the very top of your screen, and then go ahead and type in your full name and your email address, and that's what we will use for our roster for today's presentation. And I'm going to read a brief statement here related to our CEU process. The University of Kansas Health System is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. To be awarded contact hours, you must attend this program in its entirety, participate in a case study analysis to complete the program evaluation. The evaluation link will be emailed to you within a couple of weeks from our education department. Upon completion of the evaluation, you will receive an email with your CE certificate. If you do not complete the evaluation within 3 weeks from the date of the email, your CE certificate will be unobtainable. Please follow the instructions in the email that you receive within a couple of weeks. And we will now go ahead and hand this over to Dr. Poggi, who will present on the ABCs of psychotherapy.
Well, thank you very much, Tanner, and thank you everyone for joining. I saw a couple familiar faces in the crowd, but a lot of also new people that I've not met. So welcome, and thank you for letting me present for Mental Health Awareness Month. This is a fantastic venue and reflects the ongoing needs of our patients and in many ways individuals in our community. And so just again, very happy to be here and kind of thinking about the nature of, mental health awareness and, having an opportunity to talk about psychotherapy. I really kind of framed this as a way to kind of think about interacting with individuals, across the kind of biopsychosocial spectrum in terms of needs and in terms of issues. And so I pulled some of this material from what we use to train individuals in our residency program and other sources. So I hope that people here who are here today or maybe, viewing this down the road might be thinking about ways in which they can support individuals that might have, mental health, variability or neurodivergence in a variety of ways. So feel free to ask questions. I'd invite you just to, jump in, open your mic. My subjective experience is that I'm looking at a PowerPoint, and so I don't have a bunch of people up on my screen. So just feel free to interact and love to discuss these things. And I think with psychotherapy, part of it is demystifying it and learning, like, is this what I'm doing in psychotherapy? Is this a mental health intervention? Is this how you ask this question? And it's kind of hard to learn from books and slides and things like that. So feel free. We can always talk about things, as we go through a formal presentation. And I'll plan to make sure that we have a few minutes towards the end to ask questions. And we'll be talking also about some resources and things. So I want people to be able to walk away and kind of know where you can connect people if they need that. So I'll go ahead and get going here. So we'll talk a little bit about general principles and concepts involved in psychotherapy. So I really want to talk about just a little bit about definitions, who are providers, who are consumers of psychotherapy or mental health resources, and we'll talk about this in a couple of different ways as we go. I'm going to talk also about approaches to psychotherapy, kind of some of what I always think about as like the key ingredients, right? Like what makes psychotherapy take place? What are some strategies, and what do we know about psychotherapy outcomes? How does that work? And then we'll talk also about some models of psychotherapy, but I'm not going to spend a lot of time talking about, okay, this is a cognitive behavioral psychotherapy or this is a psychodynamic, but I will go over that a little bit. And then, as I mentioned, we'll be talking about applying and referring patients to psychotherapy. So general principles and concepts. Okay, so I like this definition. Okay, this is Huffman et al. 2000. And admittedly, a lot of my references are old. It's not because I'm not up to date, but I just kind of like the classics. I used to teach the history of psychology, so a lot of what I really work from is some of the kind of foundational models. But I love this definition of psychotherapy. Psychotherapy is a general term for a variety of therapeutic techniques employed to improve psychological functioning and promote adjustment to life. Okay, so what does that mean? That's a very, very broad, construct, and psychotherapy is something that is both general and specific. But I like to use this definition to kind of invite people to work from a psychotherapeutic framework. Okay, there could be a variety of things that you do, a variety of ways of supporting somebody that has some grounds in the psychological literature. So who practices it? Okay, so who provides this kind of broad umbrella of services known as psychotherapy? So psychotherapy is a professional practice, okay? And so that's to say, you don't necessarily get psychotherapy, from your best friend or your neighbor, okay? You get it from trained professionals, okay? And so when we think about integrating psychotherapy into patient care, we might be thinking about receiving psychotherapy from a licensed provider, okay, that has been trained, has a license that is, granted and maintained through ongoing education, that they receive those types of services, and maybe also other types of psychosocial support, okay? And that could involve, engagement in a variety of different points of contact in our community. So psychotherapy is provided by psychiatrists, psychologists, psychiatric nurses, social workers, counselors, and other folks, pastoral counselors, and so on. And so psychotherapy really is a protected term, like I said. Psychotherapy, just to go back a slide, even though it's a general term and there's a variety of techniques, okay, people are trained to do psychotherapy, and people are supervised, it's not the same thing as getting psychological support, although both are very important. Okay, it's important for folks to be able to get therapy as well as appropriate support in the community. So who are the consumers? Okay, so who utilizes psychotherapy, services? So this is a set of issues that has become increasingly broad in the provision of mental health, the expansion and the integration of mental health into general medical communities in terms of patient populations and things. So you can see here the first three really kind of speak to what you might consider in a individual that's having a diagnosable mental health problem, like say major depressive disorder, or maybe bipolar mood disorder or something like that. Changes and problems in thinking, feeling, and behavior. And so the way the DSM and the American Psychiatric Association and others kind of define this is, when mental processes, which are normally, very, very, very broad, very unique, very individual when it comes to a person, this is where thoughts start to appear to be influenced by a diagnosable condition, and limit, functioning in important life domains, social domains, work domains, might be bringing about danger to the individual in terms of their thoughts, feelings, and behaviors, and causes distress. So when you think about when somebody needs psychotherapy, it's not the sadness, that somebody experiences over a significant, issue in life that is going to resolve on its own. But it might be that distinction between something like that and then the emergence of grief, for instance, where a person's now starting to get distressed by, what was maybe at one point a normal psychological process. The last three, I think, really speak to the expansion of who gets referred to psychotherapy, who utilize the psychotherapy, interpersonal difficulties, life situation difficulties, and biomedical disturbances. So you can see there, this kind of is a broader set of issues that can certainly be interrelated to the other topics that were just discussed, but we're going to see this, I think, a lot in medical settings or other clinical settings where something is happening to an individual, maybe some major change has taken place, and it kind of goes beyond that normal range of reaction and resolution. So certainly we work with folks that go through this as well. In terms of diagnoses, these might be things more related to like adjustment disorder, where there's a clear stressor and there's impairment in the person's psychological health as a result. But it's tied to a particular issue. Okay, and so this really opens up the umbrella of individuals that might not have ever had, a diagnosed mental health problem in the past, but now they're having difficulties, and we can get them into therapy or provide support clinically to help facilitate that recovery from maybe an adjustment-related issue. So, any questions or comments about that overall kind of introduction here, before we kind of get into some of the kind of counseling processes I wanted to share? Well, we'll be sure to have a few minutes towards the end if anybody does, but again, feel free to jump in at any point. Okay, so looking at approaches to therapy. Okay, so how do we do this? Okay, so how do you provide effective counseling? How do you work with an individual who's going through something difficult in terms of something acquired or something that's an exacerbation of a prior issue? People might have heard about this before, but arguably it all starts with the relationship. Okay, it all starts with creating a space where the person's mental health is going to become the focus. Okay, and it's we teach folks to really be present. It's psychotherapy is something that really depends in a lot of ways on your interaction with the individual, right? And that empathy, creating a safe place, learning about things from the patient's point of view, and then taking that to move forward and provide recommendations. So I want to share actually a couple of quotes. Okay, so the first quote I want to share is from Carl Rogers. And so, people might recognize Carl Rogers and say, "Oh, yeah, I remember Carl Rogers from when I took my general psych class or what have you," right? But Carl Rogers is a really key figure in the history of psychotherapy, and was known as a humanist. The humanistic school psychotherapy. And in humanistic psychotherapy, it really emphasizes unconditional positive regard and understanding things from the patient's worldview. Okay, and so this quote I think is just unbelievable when you look at this. So I'll go ahead and read it for folks that might be listening. So Carl Rogers on empathy, and this is 1957. Okay, it's 1957. Like I said, I like the classics, but really, if you think about this, it kind of illustrates what we're talking about when we talk about doing psychotherapy with patients. So Dr. Rogers, what is empathy? If I am truly open to the way life is experienced by another person, if I can take his or her world into mine, then I risk seeing life in his or her way and of being changed myself, and we all resist change. Since we all resist change, we tend to view the other person's world only in our terms, not in his or hers. Then we analyze and evaluate it. We do not understand their world, but when the therapist does understand how it truly feels to be in another person's world, without wanting or trying to analyze or judge it, then the therapist and the client can truly blossom and grow in that climate. Okay. All right, so this is, we talk about, okay, in therapy, the notion of empathy versus sympathy, right? And what Rogers is talking about is one of the key things is to really empathize, right? And so there is this hint here at kind of transference processes, transference and countertransference about how we feel in reaction to the individual and so on, and maybe having some defensiveness in ourself, not being able to do this, not being able to really truly empathize with the person. Rogers talks about that. And according to Rogers, the key thing is to really understand things from that person's point of view. Okay, and so that is key to the therapeutic relationship. And, it's going to give you the material that you need to work with an individual, to kind of find out what their needs are, what are their strengths, what are their weaknesses, what are they ready for, right? We often talk about motivational interviewing and things like that, how we support change. And we got to find out first where they are. Okay. And so I want to share another quote here. Okay, this is from Marsha Linehan, right? And Marsha Linehan is a contemporary, psychologist. Was at the University of Washington for many years. Developed dialectical behavior therapy (DBT), which is a intensive psychotherapy for patients who have borderline personality disorder. It's been expanded to be applied in a variety of conditions beyond borderline personality disorder. But Linehan talks about the concept of radical acceptance. And so when we ask Dr. Linehan, what do you mean by acceptance? She says, by acceptance here, I mean something quite radical, namely acceptance of both the patient and the therapist, of both the therapeutic relationship and the therapeutic process, exactly as all of these are in the moment. This is not an acceptance in order to bring about change. Otherwise, it would be a change strategy. Rather, it is the therapist's willingness to find the inherent wisdom and goodness of the current moment and the participants in it, and to enter fully into the experience without judgment, blame, or manipulation. However, reality is change, and the nature of any relationship is that of reciprocal influence. So this is an interesting concept. We talk a lot of times in psychotherapy or helping patients about, being in the present moment, okay, and kind of accepting this is where things are, and recognizing that this can be very positive. There's no judgment, there's no blame, there's not a necessity necessarily to do something, to change something, right? But just being in the moment sometimes clears the way for us to move forward. And this is really kind of at the heart of, again, adding to that relationship, understanding where things are, and kind of thinking about where patients want to go in psychotherapy. What do they need? What do they want? Are they even clear on that? So facilitating acceptance really opens, paths to move forward. And so in DBT, there's a lot of discussion of, how skills and what skills and how to move forward. But this is a concept that if you look at psychotherapy academically, this concept has made its way into other modalities of psychotherapy, including models like acceptance and commitment therapy, and so on. So again, if you know the classics, if you know the basics, you can move forward in a lot of ways by helping individuals from a psychotherapeutic perspective. So we create this framework of empathy and acceptance, okay? And then, okay, this allows the patients to provide what's going on, okay? They give us the raw data, right? What are you experiencing? What are your thoughts? Okay, what's going on in the moment, and what's going on over time, right? Empathy and acceptance help us get to that material, okay? And so then, okay, what we want to do is we want to take what we know and what we can share and apply it in a way that's going to be, personally meaningful and helpful to the individual. Okay. But we have to start with that framework. Okay. The therapeutic alliance starts with building that space and then following the patient so that we can start to deliver interventions. So collaboration, okay, really key and essential to this, to creating a space where psychotherapy can take place. Okay. And then positive reinforcement. Okay. And so positive reinforcement, if, folks again are thinking back like, oh, I've heard that term before. Positive reinforcement is the notion of reinforcing behaviors and reinforcing psychological events that is going to be repeated. Okay. And so typically something positive happens. This, teaches the individual like, oh, okay, if I do this, I can feel better and I'm not going to feel, negative. I'm not going to feel the pain. Okay. And so positive reinforcement has, roots in operant conditioning and so on. But really this is what we're striving for. Okay. And so there could be a number of things that, regardless, before we get into different modalities of therapy, again, which I'll talk about, but I won't belabor, general skills, general ways to assist individuals, being assertive. Okay. I do group psychotherapy with individuals, and this is a topic that comes up very readily. How do I assert my needs? How do I talk about how I'm feeling? How do I navigate, social and interpersonal relationships? That's a huge skill. Okay. Many individuals that experience mental health difficulties or life stress, relationships are tough. The roles that they're in are tough in life. There might be things that are changing in life, and so how do you navigate that? Some of that is being, an assertive communicator, or looking at how am I approaching this? How am I communicating my needs with somebody? Okay, and so that could be considered interpersonal psychotherapy, and academically it is, but it's a really kind of essential coping skill. Learning how to be assertive. Engaging in self-help. So, taking care of one's self, okay? Asking for help, getting help between sessions, engaging in self-care. Uh, a very common issue for individuals that are receiving psychotherapy might involve, kind of biobehavioral interventions like sleep hygiene, nutrition, medication compliance. All of these things are things that are going to, potentially help a person feel better and do better and, think, better in terms of general psychological health. Utilizing support. Another, very general, very common factors type of psychotherapy is understanding what that person's support system is. As I mentioned earlier, going to the psychotherapist and, getting, some interventions and some discussion of the mental health needs. But what do you do outside of that? I mean, you're meeting with that person maybe an hour every 2 weeks, 3 weeks. I mean, the wait times and the access to mental health are really, really out of control. So building a person's engagement in their support system, okay? Is that related to their family? Is that related to their experience of spirituality or religion? Is that connected to their roots in their community? All of those places are very rich in helping the individual utilize psychosocial supports. Avoiding triggers. Okay, so this, triggers is often, like a trigger is often used in the context of maybe some kind of behavioral analysis, right? This happened and it led to this and then it led to that and so on. Hence the ABCs, which is antecedent, behavior, and consequence, which I sort of, hid into the title of my talk today. But avoiding, what are going to be triggering situations, right? Where are some areas in life where things really, we've got to, maybe avoid this for a while or come up with a plan, right? Modifying those triggers. Okay, so it is kind of like a behavioral analysis type of strategy we can use, and person can work on those things as they develop more strength and more resiliency. And so we give reinforcement. Okay, so we give reinforcement. This is like, praise, it's feedback as the person is trying to do these things, like they're showing effort, they're engaging in things. And so even if a person, works on some of these things and it doesn't reach the exact desired outcome, it's still progress, right? So validation and approximation are key concepts here, because when we talk about shifting behavior, right? Behavior doesn't change from A to B, right? There's maybe 100 little steps between A to B, right? And so when we support patients from a psychotherapeutic or a behavioral health or mental health standpoint, right, we're shaping and we're teaching and we're talking about lifestyle change. We're talking about changing behavioral processes, right? Whether how we think about it, how we handle it, if we approach things with or without social support, there's a lot of approximations towards where we're trying to get to, which are very, very valid, and are deserving to be reinforced. So, okay, so we've talked about creating the space. We've talked about some general mental health interventions, which are kind of biopsychosocial in nature. Okay, so what are some of the skills? What are some of the things that psychotherapists do? In other words, how do we do this? Okay, so first thing is listening. Okay, listening. So a lot of times we might have as they talk about in motivational interviewing, the writing reflex, right? We want to advise, we want to solve the problem, we want to get the person feeling better and moving forward. That's why we're all here, why we are all here. That's why we've worked hard to become professionals. But in psychotherapy, okay, and applications of psychotherapy, like I've been talking about, listening, okay, listening is very important, okay. And I think we all know it as human beings, like, you can tell when you're not being listened to, right? A person's not, hearing you, their agenda is more important, right? But listening is very, very key to psychotherapy and learning how we can kind of quiet ourselves, okay? And it also is very important in establishing a mental status examination. All right. So when we listen, our key skill that we're employing is observation, right? What is the person saying? How are they saying it? Okay. Why didn't they say this? Or how did, what's the, we're getting a sense of, the person's, stream of thought, for instance, right? When we listen, we get a sense of, is what they're saying consistent with the way they're presenting, right? Are they saying they feel okay, but you're seeing like tears roll down their eyes, right? Those are listening skills, listening observational skills. Okay. And one thing here is to look at just, what's the congruence or incongruence of what a person is saying, right? If we don't listen and we jump in and we solve and we correct, we might lose track of this. Okay, we might lose track of this, but listening is a key process, and it's not something that is passive. You might think, oh, psychotherapy, just listen, you know what I mean? But it's not that. It's active listening. Okay, it's hearing but also seeing. Okay, hearing and seeing what's going on and thinking as a clinician. So we'll talk about three key strategies: attending, silence, and paraphrasing and summarizing. Okay, so attending. Okay, this is how the person experiences us in the room. Okay, and so this is, as I was saying a little bit ago, it's our presence. It's how we're interacting with the individual. Okay, and so many people. Okay, there are a lot of barriers to this, and I'll start off over there. Okay, I'll start on the boundary and kind of move in. Right. Um, Providers can be very busy. Providers can be very distracted. Okay, we might be going from person to person to person, and we might be with one person but thinking about somebody else, or we might be with the person but we're looking at a device. Okay, or we're checking information. Okay, that impacts the degree of the therapeutic alliance, right? um, you know Being present, thinking about, your nonverbal communication. What's your body language? What's your posture towards the patient? Are you making eye contact? Okay. Are you smiling? Are you tracking the person with the appropriate facial expressions? Right. This is very, very key. And so I just encourage people when you're working with folks and maybe, you're in a clinical situation. Okay, let's just apply it a little bit. You're in a clinical situation and maybe you're worried about somebody that might be, very anxious or very depressed. Maybe they're even coping with something like suicidal ideation, right? We have to create that space so that we can appropriately assess it, right? So that we can ascertain, again, empathy. What's the person's experience? We're going to accept that, and then we're going to move forward, right? So it begins with, our presence in the moment. And I encourage people to think about that, being present, thinking how you can enhance your presence if it's a challenge. So kind of talked a little bit about this when talking about listening, but listening again is not a passive process. Okay, so silence is golden. All right. So we think about communication, and I'll go back a slide just to emphasize. Okay, so if we're present and we're attending to the person, we're following. Okay, that in and of itself is communication. Okay. We don't have to communicate verbally to communicate, right? And so it can acknowledge all of these points here. Okay. I'm showing respect because I understand that you're thinking about something, you're reflecting on something, right? So I'm going to give you time to formulate what you want to say. Okay. Maybe you're not quite sure what to say, right? So I don't want to jump in too quickly. You know what I mean? I don't want to interrupt that process. I want you to, be able to reflect and be clear. Okay. Um, Silence also helps individuals work through difficult emotions, right? I think we probably all had that experience where somebody is processing some challenging news or something like that. And even as individuals, our emotions can kind of well up, right? And silence and active listening kind of helps us create a space where a person can experience those emotions safely, right? Silence also helps us work through issues of trust, right? There are many folks that might have mistrust towards various systems, right? The healthcare system can be part of that. Okay. The educational system, any places where mental health services might need to get delivered, there could be some trust issues there, right? And so in that case, in addition to these others, if we're not silent and we're not giving the person the respect to share, it might reinforce a sense of mistrust. Okay. Deeper insights. Maybe a person is reaching, a greater level of understanding about something. We don't want to interrupt that process, right? And some modes of psychotherapy, that's the whole idea, is to get somebody to develop deeper insight and greater self-understanding, right? Theoretically, that can lead to a lot of corrective behavior. Okay. There might be cultural influences on how a person's going to speak to a provider. Okay. So really just kind of thinking about this, really think about your presence and using your verbal communication, using speech versus, withholding speech as a way to facilitate this, right? And thinking about this too, going back to, to Rogers and to Linehan, right? It helps us kind of empathize. It helps us put together all those observations, empathize, and get maybe a better sense of where people are at. So, of course, very important strategy. So, kind of building on this, this is kind of a watch out, be careful not to do this, right? Saying, oh, I know how you feel, right? I know how you feel. Oh, that must be tough. That must be trouble. I know how you feel. Okay. And this is kind of the negative outcome, right? It can be very invalidating, right? Um, it's much better to kind of reflect more on what the person's emotions might be, what they might have said, rather than to say, I know, right? Reflecting back what maybe you've heard, okay, what what you're wondering about, showing like a healthy curiosity rather than saying, oh, I know how you feel. Yeah, yeah, grief, it's tough. You know what I mean? Like everyone's grief, for instance, is different. You know what I mean? There might be some similarities in some ways, but the experience is our own. So kind of avoiding jumping in too quickly when providing counseling, psychotherapy services to someone. So this is kind of what we're talking about here, avoiding that pitfall and paraphrasing, right? Let me see if I understand. Okay, what I heard maybe was, did you mean that kind of asking almost permission, right? Saying like, I wonder, would it be okay? Can I ask if this happened, or can I, clarify something or something like that, right? It's kind of conceptually an interesting way of looking at things because when we do psychotherapy supervision, right? Sometimes when I talk with folks, I talk about this idea of almost like getting side by side with somebody, right? Almost like if you were sitting, like instead of facing someone and you're talking about, their issues, imagine like you're sitting on a beach side by side and you're looking at the ocean, and you're like, oh yes, yeah, I noticed this as well. When the waves come up, you feel, the breeze or what have you. You know what I mean? You try to understand things from their own personal and phenomenological standpoint. And of course, like phenomenology refers to their subjective, unique experience. Okay, so there's a lot of difference here between this idea of saying, let me try to understand, or working towards understanding, right? Versus saying, oh, I know how you feel, you know? So again, those kinds of skills help us get to those spaces when working with folks that hopefully can lead to better outcomes. So in terms of psychotherapy orientations, now what I'd like to say is that the things that we've talked about have been general approaches to working in some of these other maybe schools of thought, these strategies, right? And I think if you're coming into learning about psychotherapy, you've heard a lot about, different acronyms. You've heard about ACT and CBT and RET and REBT and IPT and all this stuff, and it's all these this like alphabet soup, right? Um, if you have become more familiar with psychotherapy, you understand that these are really kind of broad branches of ideas, right? That um, intersect, they overlap, they emphasize different things. Okay, so I do want to talk just a little bit about what those main kind of branches or schools of psychotherapy really are. Okay, so the first one, psychoanalysis and psychodynamic psychotherapy. Psychoanalysis and psychodynamic therapies are therapies that look at the concepts really of like development and the development of patterns when you interact with individuals, things like attachment, self-concept. There can be things that happen during our development that might be very significant and influence us again and again and again in life. Okay, and so within that, we might notice that there are some defenses that we have, right? Some things that we've acquired, we continue to do, but we may not be fully aware of it, for instance, right? And some of these things are more or less adaptive, in terms of what are known as like ego defenses, right? And so psychoanalytic and psychodynamic psychotherapy has a very broad and rich history. It tends to be a more long-term type of psychotherapy. People might be in psychoanalysis or in psychodynamic for a very long period of time. It can also be time limited, but it traditionally has been a much longer term kind of psychotherapy orientation. Cognitive behavioral therapy is contemporary therapy, as is psychoanalysis and psychodynamics. Don't let me speak incorrectly. But cognitive behavioral therapy really looks more at the particular behavior that's taking place or behavioral kind of set, some of the issues that might be going on. And it really looks at how people think, feel, and behave, and how these things are related to each other, how they get triggered, how they get brought on, what kinds of things reinforce them, and then looking about how you can kind of pull those apart, right? So we talk about, cognitive reframing, or, changing, the behaviors that we do in certain situations, or increasing behaviors, right? So, when we think about anxiety or post-traumatic stress disorder or something like that, we might be using a very cognitive behavioral framework to help the person, reduce the number of times they avoid something that, brings up the anxiety associated with trauma, right? So that those exposures can lead to exploration of those thoughts and evaluation. Was the thought accurate? Was it inaccurate? Did what we expect happen? Did it happen? And really kind of look at those kind of contextual factors. And it might look back to the past. It might look back to our developmental roots, like, psychodynamic or psychoanalytic might, but it might not also, right? But it's, very applied. It tends to be a little bit more time limited, in case you're wanting to refer somebody to therapy. And a lot of practitioners are trained in CBT in a lot of cases. It's a very prevalent school of thought. Humanistic psychotherapy is, I kind of mentioned, Carl Rogers, really empathizing with the person, consistent with a kind of supportive mode of psychotherapy, understanding the person, understanding where they are, where they're trying to get to, and trying to facilitate that, And so I don't view, humanistic therapies and supportive therapies as passive. Humanistic and supportive therapies can often be a very strong foundation to doing some of these other things as well. And it builds really on some of the things that we really kind of recognize over time as key things that are able to provide therapeutic effect for patients. Behavioral therapy is very, very similar to cognitive behavioral therapy, but these might be things like, primarily like exposures, or behavioral activation, like, setting up a schedule, doing more and more of a certain thing, reducing the number of times that people do other things, right? But really focusing on the behavior and kind of shaping the behavior. And then group, couples, and family therapy. As this kind of implies, these are going to be psychotherapy situations in which the client, the consumer, is more than one person, right? Maybe it's a family, for instance, right? And you are looking at how behaviors and how the development of behaviors are acquired and how they're maintained in this particular social group. Okay. And so, good news, all of these modalities show effectiveness. They've all been beneficial. So we'll talk about outcome studies in psychotherapy. So there's a number of studies like this, and I do like to share this data and data like this with people who are learning about psychotherapy. Is that, psychotherapy tends to be relatively robust, okay? It tends to be effective in a lot of cases. That's not to say psychotherapy can't be harmful, okay? Different negative outcomes can come from psychotherapy. But in general, it's got a pretty good track record, okay? And I use the term robust because psychotherapies can be very manualized. They can be very, very specific. And, we see very technical administrations of psychotherapy, like in clinical trials research, or in, effectiveness studies and things like that. And that shows effectiveness, as well as some of the things that we've talked about today. So you can see here, the specific type of treatment is not a specific factor according to this. And so if we go back to this, it's not necessarily one of these is going to be key. how closely aligned or how academically correct psychotherapy is done. That doesn't seem to be a factor. Okay. Um, the person's kind of genuineness, if you look at 4, 5, and 6, okay, the person being present, working on the therapy with the patient, having a positive presence, okay, the alliance, okay, those are all things that historically have been shown to favor positive psychotherapy outcomes, regardless of modality, okay. And so these are what are considered, general factors, or what are called common factors. And so if anybody goes and looks at, common factors, you'll see a lot of this. But that's not to be said that there aren't um, some data that support specificity in different psychotherapies. Okay, and so short term versus long term. In terms of whether or not the patient continues in psychotherapy for a long period of time or a short period of time. Is some evidence that specific approaches for specific diagnoses tends to show some favorability. Okay. And so, there's an interesting literature out there about this, but, lack of specificity is also shown. And then probably one of the bigger things to think about is just, holistic care. Okay. So, psychotherapy in combination with pharmacotherapy, tends to produce, more reliable and durable effects. And there might be scenarios in which medication is going to be very, very important, if not essential, to help individuals get into effective psychotherapy. So other factors here, talking a little bit about making a diagnosis. People might be reluctant to diagnose or suggest there's a diagnosis. And there is, the issue of stigma, right? People can feel very stigmatized to have a diagnosis. But I will say it can also bring a sigh of relief, because now a person kind of knows what's going on. Other people have gone through this. Hey, guess what? There's people I can talk to that understand this. Okay. And so there's a, potential for normalization when we get into a diagnosis. Okay. And then some of the other things that we've talked about, therapist characteristics, being a professional, making a specific time and place for therapy. All of these things have also been shown to be related to kind of positive outcomes. Okay, so moving into the last few minutes, I recognize we've got about 15 more minutes. So I wanted to talk about how we get people into psychotherapy. Okay, and so I want to just kind of reiterate. Okay, there's a broad umbrella of individuals who are going to consume psychotherapy and mental health resources. We talked a little bit about that early on. Okay. So there are a wide range of folks that might be going into therapy for a short period of time or a longer period of time. Okay. So here are a number of resources, and feel free, we can maybe start to discuss things if anyone has questions. I just did some brainstorming on this and put all this up on the board. But probably a key resource is to, if a person is insured, there are folks that are underinsured and non-insured. But we oftentimes will start with, if a person is insured, contacting their insurance company and finding a list of providers that they can access, and being very clear about that. Here are a list of folks. You can go here, how much it's going to, cost. Here's how long you can go. Those kinds of things. But again, not everyone, has that, and so there are some certainly some shortfalls and some gaps in that. Psychology Today, I don't know if people have looked at that. You can certainly drop that into a search engine, and Psychology Today will have a list of providers, licensed providers. They will describe their approach to therapy, who they see, the things that they work on with patients, but it's kind of like an online resource for psychotherapy providers. This is something that is very commonly used to get patients connected. Mental health, okay, community mental health. And so here in the Kansas City area, there are community-based mental health systems. Wyandotte Mental Health Center, Johnson County Mental Health Center, and these are systems. There's also Swope Behavioral Health and Tri-County in the Missouri, Missouri quote unquote side. But there's a lot of community mental health resources. Um, and a lot of mental health, is practiced, in the community, as opposed to maybe a hospital or so on. The VA, if individuals have been involved with the military or have access to VA services, the VA, has, robust mental health and psychotherapy resources for folks to utilize. There are health systems, here in the metro area. The University of Kansas Health System, we certainly have psychotherapy providers. University Health System, Carondelet, HCA Midwest, folks throughout the community. I also wanted to put on the board here some national resources. The National Institute of Health and the National Institute of Mental Health, so NIH and NIMH. If you go and you look on their sites, they'll have numbers and points of contact to gain more information about diagnoses, treatment. They even have information on clinical trials and research that people can access. And that might be one way if somebody has, problems accessing, maybe that's a way to get them connected. The National Alliance on Mental Illness, NAMI. This is a nationwide organization that provides kind of hands-on resources and information to individuals. And so if you utilize NAMI, people can call and actually talk with someone about a range of services, both formal, you know what I mean, in terms of like providers, as well as informal and community-based services, like maybe like Alcoholics Anonymous meetings or Narcotics Anonymous and so on. And so great resource for folks. High schools and universities often have mental health and counseling services that can be accessed. Places of worship, mentioned support groups just moments ago. Heartland Regional Alcohol and Drug Assessment Center, RADAC, is a center that provides services to individuals with substance use disorders, and that's a very common set of comorbidities that we see when individuals need mental health or psychotherapy services. Rose Brooks, which is an exceptional organization, helps individuals, with domestic violence. It really supports women and children, but it's, domestic violence centric organization. And those services can be critically important at the appropriate time. And then I also wanted to share just some crisis hotlines. So I have the National Suicide and Crisis Hotline and a variety of places where people can call and talk to somebody, if they need that kind of acute support. So again, kind of the goal of this presentation was to kind of talk about, what psychotherapy is, what it isn't, how to, do some of the ABCs psychotherapy, how to interact with folks, and just kind of being more mindful and kind of practicing those skills as practitioners. We've talked a little bit about modalities of therapy and, what things can look like, what to expect. We've talked a little bit about, maybe what is essential to psychotherapy effectiveness, as well as a little bit of specificity and different things that are going to be helpful for folks. And then we talked a little bit about connecting folks. So with that, I'd love to kind of hear from folks. I'll do the best I can to answer any questions you may have. But again, thank you for letting me present this afternoon.
Hi, Dr. Poggi. This is Ashton. I do have one question,
Yeah.
kind of going back to the discussion about empathy. So, is there ever a point that you've seen where maybe being too empathetic can be almost enabling for the patients? Like if you start to see them regressing or feeling like they're taking advantage of that empathy, and how do you correct that if you find yourself in that situation?
Yeah, that's a great question. I think maybe that can become maybe, part of the discussion of empathy where, you kind of reflect that back gently, right? And see how a person can process that, if that makes sense.
It does. Thank you.
Yeah. Other questions? That was a great question about empathy. And I don't, if we want to spend more time on that, I think we can. Um, Maybe a follow-up until there's another question posed. I would also kind of take in balance, if a person is coming into treatment, you know what I mean, and you're seeing them clinically, to me, the empathy would be that, maybe there's some reoccurring problems, so the person is still working on it. You know what I mean? They're just still coming in because if they, were not motivated for change, and arguably they wouldn't be coming to see us too. And so maybe bringing that in. One additional comment I'll talk about is, according to Rogers, Rogers talked about empathy and reflection, as really kind of key core interventions. But he talked about reflecting, summarizing, and then doing a higher order reflection, which would say, this seems like it's been a problem. You've been working on it. We've been talking about X, Y, and Z. We've made some progress, but we're still seeing some difficulty, right? So kind of incorporating and summarizing both like, the clinical, as well as the, the subjective experience of the patient, kind of what you're seeing as a professional and what the patient's going through. Other questions or comments?
Dr. Poja, I had a quick question for you.
Yeah.
Just in your practice, what do you find to be the most rewarding? Just in your time working in healthcare and in your time with patients, what are the most rewarding parts of what you do?
Oh, that's a great question. Well, I feel very fortunate because I get to work with people on an individual level. I do group, I do psychological assessment, I do a lot of teaching, I do a lot of team-based clinical work. But I don't know. I don't know. I feel like well, I'll just kind of share. It's kind of recency effect. I mean, you can kind of see when people are making progress, and it's so rewarding, and I think that, mental health conditions are among some of the most disabling things that people experience. I mean, that's one of the reasons I do what I do. And so just seeing like the progress that people make, big or small, is the most rewarding thing. And I think that could be kind of behavior change. Certainly, it can be development of insight. Um, I really love it when we can, as a team, kind of get it like a good diagnosis and a good treatment plan for someone. So I don't know. I'm easy to please when it comes to that, I guess. So, but I guess I really feel fortunate. Really, I admire people. You know what I mean, and what people experience. And so, there's a lot of reward in that.
Do you ever lead any lectures on group facilitation?
I do, yeah, in our residency program, yeah, for sure. And I'm glad you brought that up because, when Tanner asked that question, we have some really good groups. We didn't talk a lot about group therapy, but group is a modality where things kind of emerge. People say things, people interact with one another. They develop that support while they're also working on receiving some therapy. And so to me, it's kind of a more potent mode of therapy because there are multiple kind of restorative and therapeutic processes that are happening all at the same time. Thank you for that question. Okay, well, I'll go ahead and stop there. Feel free to email me if you have any questions at all. Again, thank you for all the efforts of putting all the curriculum on us, looking at all the things that have been presented this month, and thank you so much for having me. I'm always just an email away, so feel free to reach out and contact me. And I hope this has been helpful. Again, this has been the ABCs of Psychotherapy, so hope everyone has a great weekend.
Thank you, Dr. Poggi. Have a wonderful weekend.
You too. Thank you.